Good afternoon. Hi, my name is Blake Daniels. I'm the chairman of the Board of Commissioners for North Oaks, and it's my honor to welcome you all to this inaugural North Oaks Community Forum. This is a first for us, as many of you know. We are quite excited about this, maybe a little nervous as well. Who knows what will happen, but we certainly thank you all for your attendance and thereby helping us to be able to offer the best health care possible to the citizens of the parishes that we serve. Please note that on the chair where you're sitting, either on the chair or under the chair, there are some question cards. During the program, if questions come up in your mind, or if you know of something now, please write your question on the card and then just hold it up like this, and one of the North Oaks staff will come and pick it up, and we will attempt to address that after the formal presentation. Additionally, you're also going to find an evaluation form there. Please, I know they're a pain to fill out when I go to seminars. I don't want to do them either, but they really do help us, especially since this is our first one. They help us to be able to do a better job in the future. And that's certainly what we want to do, is to make the next community forum even better than this one. All right, so I would like to recognize my fellow members of the Board of Commissioners. I would ask you to stand when I call your name and remain standing until all have been called. First, Ms. Jocelyn Lee, Dr. Ann Carruth, Mr. Ron Macaluso, and we have one more who informed us he's going to be a few minutes late, Dr. Bob Barsley. He'll be running in just a minute, I believe. Thank you all very much. Okay. Let's get it the right way. Okay, next, I would like to introduce the executive team of North Oaks. I'll ask also, when I call your name, if you would stand and remain standing until we're all recognized. We'll start off with Ms. Tracy Randazzo, Vice President of Strategy and Outreach. Larry Daigle, Vice President, Performance Management. Dr. Herbert Robertson, Chief Health Informatics Officer. Sybil Paulson, North Oaks Rehabilitation Hospital Administrator. Percival Kane, Chief Ambulatory Officer. Jeff Jarrow, Chief Human Resources Officer. Shirley Zing, Chief Financial Officer. John Derenbecker, Chief Legal Officer. Shelley Welch, Chief Clinical Officer. Dr. Robert Pelche, Chief Medical Officer. Michael Watkins, Chief Operations Officer. And last but not least, Michelle Sutton, our President and CEO. So thank you. And at this point, I'm going to turn the program over to Michelle to take us the rest of the way. Thank you.
And I too would like to welcome you all this evening. And tonight's program wouldn't have been possible had it not been for some community advisory groups, pastoral advisory groups, and our foundation. So at this time, I would like to recognize 3 members from our community who gave me the information to develop tonight's program. And I'd ask that you stand and be recognized when I call your name. The first one is Mr. Larry Bordelais, Ms. Elizabeth DePaula, and Mrs. Cannon. Thank you. Also, members of the North Oaks Foundation, they're here and they helped as well. So if you all would please stand and be recognized. Thank you. So as we were working on the program, we thought for our first community forum, what we wanted to do was to address the myths and misinformation circulating around the community and give you the facts. So for the first one, I pay taxes to support North Oaks. I can't tell you how many times we hear that. And we have not received any tax dollars since 1985, and it was for tax year 1984. And even at that time, it was around $30,000. And the reason why we received tax dollars back then was because when the hospital was formed in the early 50s, there was a committee made up of citizens of both Hammond and Ponchatoula who came together at the request of Mrs. Mary Anton, whose son had fallen and needed to get to an emergency room. And as they were trying to get to New Orleans, the Manchac Bridge was up and she couldn't get there. And so she came back and said, we need a hospital in this community. And that's how North Oaks came to be. And they went to the state legislature. The service district was formed, so we are a political subdivision of this state. And what they did was they applied for a $1 million grant from the federal government. It was Hill-Burton grant dollars. $850,000 was to construct the first hospital that had 60 beds, and $150,000 was for all of the furnishings and equipment. From 1960 until 2017, we are now the largest community-based health system in Louisiana on the North Shore. We also have now 2 hospitals, 34 practices, 2 outpatient diagnostic centers, a radiology school, a dietetic internship, and a freestanding rehab building as well. So we've grown quite a bit over the years. Our 60-bed initial hospital is now 330 beds, and you'll hear a little bit more about it later. The next myth: North Oaks makes a profit on each patient we treat. So the myth was that we're rolling in the dough, but we're really not. Because of our payer mix, 80% of our patients are covered by Medicare or Medicaid. We love all of our patients. We don't necessarily like their insurance plans because Medicare and Medicaid do not cover our cost. And to demonstrate that point, these are our audited financials from fiscal year 2016. And this shows you that for Medicare, Medicaid, and uninsured that came through our doors, we had $42.5 million worth of care we paid for that we didn't get reimbursed. So we had to pay for their drugs, the salaries, electricity, but Medicare and Medicaid didn't cover the cost. Myth number 3, North Oaks does not provide high quality care. North Oaks' performance is monitored by many outside agencies, and that is simply not true. They ensure that we provide high quality care. And to demonstrate that point, these are a few of the governing agencies that monitor us. One is the Joint Commission. The next is CARF, which stands for the Commission of Accredited Rehab Facilities for our rehab hospital. The American Hospital Association. We actually just won an award from Blue Cross Blue Shield for our maternity care as being the best on the North Shore. We're a blue ribbon center of distinction. We also were recognized by GIFT for our OB care in doing what's called skin to skin with babies, as well as for breastfeeding. Then I know you all have heard about our trauma program, or at least I hope you've heard about our trauma program, and the American College of Surgeons came in and verified that the care we were providing was excellent. In addition, you may recognize some of the names up there: Cleveland Clinic, Johns Hopkins, and the University of Pennsylvania Medical Center have come in to learn from our team for different things here because we were touted in the country as being the best of the best. In addition, if you go to the Medicare, it's called CMS, the Centers for Medicare and Medicaid's website, they have a website that's Hospital Compare. And when you compare us to our top 2 competitors, equal in size, that being Our Lady of the Lake and Ochsner, you can see that North Oaks has 3 stars and the other 2 have 2 stars. But we're not satisfied with just 3 stars. We're here to tell you we want a 5-star rating, and we're going to continue to work hard for you to get to those 5 stars. And so 5 stars means excellent, 4 is above average, and 3 is average. So it means we're doing a good job, but we don't want to just do a good job. We want to do a phenomenal job. The next myth: you have to go to New Orleans or Baton Rouge to have the best doctors and nurses. Again, the fact is over 20% of our nurses have continuing education and advanced certifications in specialties. In addition, Our doctors come here from all over the country. They have trained in world-renowned programs, but they choose to come to this facility to work because of our staff, because of our staff's competency. They know that they're putting their license in our staff's hands, and they're proud to work with our team. In addition, when they go out and recruit their friends to come work here, it's because of the product that we have. They want to work at a good facility because their reputation relies on it. So to talk a little bit about our doctors, I'm going to ask our Chief Medical Officer, Rob Heltier, to come up.
Good evening, everybody, and thank you for really caring enough about your community and your community hospital to be here tonight. I want to point out what you're seeing here, and there's two slides that are of equal length, are the physicians that are coming in this year. The reason, and Michelle just touched on it, the facilities that have been built and the reputation that has been built, not in the last year or two, but in the ongoing years as we've continued to grow and add specialties, add services, add technologies, allowed me as one of my jobs is to recruit physicians. It's really made it easier and easier every year to attract those high quality physicians. That's page 1 and page 2. You can see most of them are starting in August. These are essentially residents that are coming out, and they are from all over. A good example of that, I'm proud to be able to introduce Dr. Niksad Abraham, who's going to come up and talk to you about something in just a second. He's a graduate. He finished his program at Jefferson College, Northeast Connecticut, right? Pennsylvania. I'm sorry, Jeff. I should have known that. Jefferson College, where he did both internal medicine, then stayed on and did both cardiology and interventional cardiology. He's going to talk to you about one of our specialties that's here. Next.
Thank you, Rob, and thank you everybody for having me here to talk a little bit about a new procedure that we've been doing here since 2014. I moved here in 2013, and at that time I didn't know what I was getting into. I thought maybe I'll stay here for a year and see how things go. So being freshly out of my fellowship, I just want to try it out and see how things went here. But since then, everything has been great and wonderful, and this is my 5th year, and I bought a house in Hammond, and I don't know, I think I'm going to be stuck here. All right, so I'm just going to talk a little bit about this procedure. So mainly talking about what we commonly known as hole in the heart, and the other scientific term is ASD or PFO. You know, everybody is born with a hole in the heart. You all know that, right? Yes? All right, so let's talk a little bit about it. So ASD or atrial septal defect, this is a congenital condition. That means this is something you're born with. And in this problem, there is actually a defect or a hole in the wall that separates the two upper chambers of the heart. And this is pretty relatively rare. You see that in 1 in 2,000 people. And the other condition, a little bit more about the atrial septal defect. What this causes symptoms like difficulty breathing. In kids, it causes frequent respiratory infections, and eventually it causes your heart to get enlarged, and it causes irregular heartbeat, atrial fibrillation, heart failure, and sometimes it can cause a stroke. So some people, young people come in with a stroke, and we do all kinds of testing, and we find that they are born with a hole in their heart. And it's quite surprising for them to realize that they are born with a big hole in their heart, and nobody has diagnosed, or the pediatrician never told them that they have a murmur or a hole in their heart. The fact is that these are very silent, and unless you really look for it, you won't find it. So my interest in atrial septal defect started when I was in medical school back in India. And when I was in my fellowship and all, we started this new program and new technique of closing this hole using a catheter. So that's why I was more interested in it. And when I came down here, we were able to start this program here. So the other variety of this is called a PFO, or a patent foramen ovale. this is a hole that everybody is born with. Everybody is born with this hole because when you're in the uterus, in your mom's uterus, you need this hole to bypass your own lungs because you're not breathing when you're in the uterus. So everybody is born with this, but some people, in about 25 to 30% of people, this stay open. This doesn't close. So this can eventually might cause a problem. Okay, so it can manifest in terms of causing a stroke or bad migraine headaches or any kind of atrial arrhythmias like atrial fibrillation. So again, this is also diagnosed when a young patient comes in with a stroke. So this is side-by-side picture of what I'm talking about, the ASD and the PFO. You can see in the ASD you have a bigger defect actually, whereas in the PFO it's like a small track. How do you diagnose an ASD or a PFO? Again, it's by using a simple ultrasound technique, and sometimes we use what we call a bubble study, which we agitate a saline and inject it through the IV, and we can see the bubbles cross through this defect. And the picture on your left is the ASD, and the picture on the right is the PFO. So you can see the ASD is a much bigger defect, whereas in PFO it's a tiny defect. All right. When do you need to treat them? So symptoms of heart failure, enlarged heart, irregularities in the heart rhythm, stroke, those are the reasons to treat an ASD. Whereas in a PFO, you treat it only if you see a stroke in a young patient, and usually between the ages of 18 to 60. So some people have PFOs when they are in their 70s or 80s. They don't need to be treated. But a young patient, and you cannot explain why they had a stroke, and if you find a PFO, that'll be the right person to close the PFO. How do you close it? So this is the small device that we go through, put it through the vein and go to your heart, and it actually essentially plug the hole. So you can see the step 1, 2, 3, and 4. We cross through the hole, put this plug across that hole, and then you come out. It takes about half an hour to do it, and it's very minimally invasive. It's patients go home the next day, and recovery time is absolutely zero. Back in the days, about 10 years or more, this was done using an open heart surgery. So you can imagine the recovery time from an open heart surgery is about multiple days or weeks, but compared to that, this is equally same result with no recovery time at all. So this is an ultrasound picture of a live image. You can see the defect on the right side. The top images, you can see the color and without the color, and how it looks after we closed it. So that's the small device. It's called an ASD closure device. So as I said, I started this program here back in 2014. We did our first case in January in Hammond, and since then we have treated approximately 55 cases, and most of the patients were unexplained stroke in young people who was found to have a ASD subsequently. All right, having said that, I think I'll call Dr. Duke. It's going to be Dr. Duke.
It's going to be me. Dr. Duke was good enough to make my point, which I'll be making in a second, that we have dedicated resources to trauma. Currently, Dr. Duke is in the OR with a trauma that came in just a few minutes ago, and directly within just a few minutes of getting here, went straight to the OR to get this guy's spleen out, which was bleeding. And so this is, I'll talk a little bit about his program for him. I do want to recognize, I know I have some people from our trauma team. Would you guys stand up? Let me tell you a bit, thank you guys. Let me tell you a little bit about what being a designated trauma center means. If you go back a few years before we were a designated trauma center, and you got in a significant car wreck, fall, any of those things that caused issues that needed immediate care, and you needed to be transferred to a trauma center, your closest one was 45 minutes away in New Orleans. The American College of Surgeons came to us a number of years back and said our goal is for everyone in Louisiana to be within 1 hour of a trauma center, because the data shows that those people that can get to a trauma center within 1 hour, which I'll show you later, is called the golden hour, their morbidity and mortality, their risk of having bad outcomes, including death, drops exponentially. So in 2012, we started that journey, and in 2016, we got our designation. So what does that designation mean? What it means is what we had before was fantastic. We had a number of general surgeons here that over the years treated everything. They treated the people that came in with appendectomies, and they treated the people that came in with car wrecks. But they weren't dedicated, and to be honest with you, they didn't stay in-house 24 hours a day like these gentlemen and ladies do now, waiting for that to happen. We have a trauma activation like what just happened a few minutes ago. Within 10 minutes, 15 minutes tops, our entire team is assembled down in the emergency department waiting for that ambulance to show up, and they usually get enough information from the ambulance that they know some of the things they have to do immediately. They're in our CAT scanner immediately. If they need to, they go straight to the OR. There is no stopping this team, and we've had multiple meetings on how to cut minutes out of things like getting blood to the patients, which has really advanced our care and reduced the mortality, and the stuff that we can do now because of this team is amazing. Again, here's that golden hour that we talked about, and having these resources dedicated makes a big difference in people's outcome. In a yearly basis, in this past year, we had 12,000, half of which had to be admitted by our trauma service. A significant benefit to the people of our parish and our community.
Our next myth: North Oaks has a high infection rate. The Centers for Medicare and Medicaid confirm that North Oaks does not have a high hospital-acquired infection rate. Additionally, we have taken aggressive steps to try to stop the MRSA that's out in our community because we have a high incidence of it. So this is the dashboard that comes from Hospital Compare that shows us compared to our competitors, and you can see we're very similar. And the one area where we are red, that has to do with MRSA, which is everywhere in the community. Probably if we swabbed everybody in this room, there may be one or two who doesn't have it. And so when you come into the hospital, if we don't know in advance that you have it and give you antibiotics prophylactically, which means preventatively to help treat it, then it does look like you have a hospital-acquired condition. And that's why you hear so many people get an infection in a hospital. It's not that they get it, it's that they come in with it, but it manifests while they're here because their immune system's compromised. This is the one that drives me crazy the most, and that is the myth that people call us death oaks. And we do not, let me say that one more time, we do not have a high mortality rate. We are the largest hospital in the North Shore. We are what is called a tertiary center, which means that the smaller hospitals transfer their sickest of the sick patients to us. We receive about 500 patients a month through our emergency department to be admitted to our facility. They're coming from the smaller hospitals where people are really sick. So there is an expected amount of patients who are supposed to, it's just their time, pass away here. And so when you look at it by the numbers, you can see right here that compared to our competitors, we're doing very well. The people who pass away here are expected to pass away here based upon their conditions. A lot of people don't realize how large we are and the fact that the smaller hospitals are transferring into us because of the caliber of care that we provide. We have both an intensive care unit as well as a surgical ICU, and then we have the trauma program as well. Wait times in the emergency department are long. That's another myth. The fact is, if you are in a true emergency, if you are in a life-threatening situation or a limb-threatening situation, you're going to be taken care of immediately. There's not going to be a wait. The people who do wait for periods of time are those people who have less severe conditions. We understand it's important to you if it's your small child that's running a high fever, but if it's a gunshot wound who's bleeding out, that's going to take precedent. And so when you compare us to other large hospital service large emergency departments, we treat about 81,000 patients through our emergency department. We're the second largest in the state of Louisiana. So when you compare us to two other large, high-volume competitors, emergency departments, you can see our wait times are much less because you have to compare us to like facilities with like volumes for our wait times. The gold line that you see going across the top, that's the national benchmark. And you can see how much smaller. We are the one all the way to the left. And our wait times are much less than our competitors. And this is from ED to admitted. So from the time you roll into our emergency department to the time you're admitted. The next one is from patients being seen in the ED, emergency department, before they are discharged. You can see again, we're much less. The only one that we have a small blip is on from door to doctor seeing. And it's only by 1 minute that we're off from the nation, and we're 2 minutes behind our next closest competitor. So we don't have long wait times for true emergencies. You may have a long wait time if it's something that is not life or death. Number 8, North Oaks is not helping improve the health of our community. And again, the fact is we have been recognized nationally for some of our innovative programs. One is with the Antimicrobial Stewardship Program, which means that our pharmacists who are specialized are decreasing superbugs. They're working with our doctors to ensure that we're not giving too many antibiotics and creating bugs that are now resistant to drugs. We were recognized out of 3,700 hospitals across the United States as the only one to come up with this idea, put it in place, decrease the superbug, and save $2.6 million while doing so. In addition, North Oaks had a very high readmission rate. Within 30 days, patients were coming back in. So when we drilled down to see why were these patients coming back in, a lot of it had to do with societal issues. The patient didn't have transportation. Maybe they were wheelchair bound and didn't have a handicap ramp to get out of their homes, or they couldn't afford their medications, or they didn't have electricity, they didn't have running water. How did we find this out? We actually partnered with Southeastern Louisiana University, and they are putting healthcare coaches into the homes with us for these patients that, using analytics, tells us have the highest propensity to be readmitted to our facility. In that target population, in the first 18 months, we were able to decrease in that target population their readmissions within 30 days by 78%. And those healthcare coaches, working with our nursing staff, our doctors, our pharmacists, our dietitians, we were able to get the Council on Aging to deliver meals, to make sure they had balanced meals. If they had congestive heart failure, we were putting scales in their homes so that they could weigh themselves and be monitored. We would make sure we could get drugs to them. We took them to doctor's appointments. And then there's one other way we're improving the health of our community, and that program is through a new department that we started, and it's called Health and Business Analytics. And to talk a little bit about that, I'm going to ask our Chief Operating Officer, Michael Watkins, to come up.
Good evening. So a lot's changed in North Oaks in the last 5 years, and I'd like to start with this picture, right? So about 4 years ago, we implemented and invested in an electronic health record. So before that time, this is kind of what our file rooms look like. Now they look like this, right? This to this, right? This houses about probably 5 big buildings of these. So if you've been a patient at North Oaks, say in the last 5 years, right, you've seen that change, and what have you noticed? You've noticed that when you come in, not only, for instance, this is an emergency treatment room. You can see the stretcher, and you can see, there's the med gases on the back wall, there's the exam light, there's all that equipment you need when you have something come in, but there's also something else in there now, and that's that computer sitting there, right? And how important has that become in how we treat patients? So that's what we want to talk a little bit about. So as Michelle said, we formed a new department last June, Health and Business Analytics. We took a group of highly talented people we had, clinicians and technicians, and put them together, and we said, okay, how are we going to use all of this data we've been collecting for the last 4 years, and how are we going to really use it to improve the health of our population? The department's led by Dr. Robinson, who's been introduced. He's our Chief Health Informatics Officer. He's also board certified in clinical informatics, which is really uncommon, or I'm going to not say uncommon, I'm just going to say it's a rare certification, and we're very lucky to have him here. In the system now, we have what are called best practice alerts that shoot off, right? So in the course of treating a patient, what happens is we have, if you're on the internet at all, and you know what a pop-up is, right? Something pops up in your face or an alert and says, hey, you need to do something, right? So we have these best practice advisories that pop up. So these alerts come up, right? And they range from, hey, this patient is missing their flu shot, or it may even range to, hey, this patient is at risk of having a blood clot, and an intervention needs to take place. So in a 24-hour period, in our system, about 5,000 of those different alerts shoot off. And that does not even include another 3,500 that shoot off just for our pharmacists, just for when they're looking at medicines and drug interactions and those kind of things. So we already have some things in place that this health electronic health record is really buying us really a lot of intervention already, and it really is making patient care a lot safer. So let's talk a little bit about population health and what we're doing there, right? So when we're talking about groups of individuals, for instance, women, I guess, that need breast cancer screening.
Right.
What are we doing there?
So we would like to be able to reach out to our patients that we know need care, and not always necessarily when you came to see me. So if, for example, for our patients who may have missed their screening for breast cancer or may have not been screened and would be my patient or our patients or any clinician's patients at North Oaks, because we all use the same system, they could find out they've missed their screening, and we could contact them and have them come in and take care of that. We can also provide that information for some of our care staff so that they can help communicate with you and set up appointments if you'd like.
Okay, another thing I know we wanted to talk about was people come in, like say through the emergency room, and they have a high-risk condition that we need to identify, and sepsis being one of those. We want to talk a little bit about sepsis and what we're doing.
Yeah, so I don't know if you know what sepsis is, but you may have had a family member who's been septic, and I hope not, but it's certainly a common condition. You've certainly all had infections, throat infections, strep throat, urinary tract infection, sinus infection. When the bacteria get in your bloodstream, you can become septic. The epidemiologic evidence in our country shows that about 3 out of every 1,000 people experience that condition. That being the case, we have a community and surrounding area of almost 500,000 people. That's about 1,500 people that are at risk or going to come in with septic or near septic conditions. We know that by identifying that very quickly, we can offer you antibiotics and other treatments which can help save your life. You don't have a very long time. We talked with trauma, sometimes you don't even have an hour. With sepsis, well, you want to be on treatment within 4 to 12 hours. We've already instituted some detection mechanisms when you come in to see if you might be at risk for sepsis, so that we can immediately draw those types of tests that we can determine how sick you are and get involved in your care immediately in terms of treatment of sepsis. Currently, our system and our team have worked together to develop a risk model for sepsis that will monitor our patients when they come into the hospital and every 15 minutes to see if at any point in time their condition starts to worsen where they could be becoming septic. If we see that happening, we can notify our providers immediately and we can have them intervene. If you become septic and it becomes severe, you come into a condition called shock where your blood pressure gets very low. Your chances of dying are about 50%. If you multiply those numbers out times the numbers you saw in the community and across our country, that's a lot of people who can die from this disease. We think that by early intervention, we can prevent you from getting severely septic or into septic shock, and we hope we can reduce the mortality. Maybe cut it in half, maybe even more. And those are real people in our community that we see. We've gotten this ramped up. We've done some research on it. We've worked with other institutions. It's being enacted at our organization right now, and we're excited about that development and about our team's opportunity to participate in that.
Okay. I know we probably take more time than we're supposed to. If you want to.
Yeah, and just in closing, there's lots of other diseases and things that we can pick up. We're not just treating one disease. We just wanted to share with you a little bit about what we do and about how seriously we take it and how we want to give everybody 100% correct care, 100% time, every time you walk in the door, all the care that you need. Some other things you'll see up there are stroke, drug interactions, some things you may not know what they are, kidney damage, weight loss, cancer, a lot of those other things we're looking for. And when you come in, we're looking for those kind of things and trying to make sure that we can detect them at the earliest possible moment, get your doctor and caregivers involved immediately, and get you the treatment you need. So we're excited to share that with y'all. So thank you.
So hopefully you've been able to see that we have a team committed to improving lives every time, every touch. And our 2,600 employees, over 400 doctors, over 300 volunteers are committed to making a difference. And we believe healthcare is a calling, that we're here for a purpose. And one of the greatest things I get to do as CEO is get feedback from our community. And shortly after I became CEO, I received a letter from a member of our community. And the letter touched me because it was a glowing example of why we're here and how we're trying to make a difference. So I reached out to Miss Fay and I asked her, would she be willing to let me read her letter and film her so that I could share it with our staff? Because I wanted our staff to hear from a real patient about her experience. And she graciously agreed to. So here is Miss Fay's story.
I was admitted to North Oaks on February 6th and released on February 16th. I came through the emergency room and I don't think I have ever been treated so fast and so carefully. I can't remember the doctor's name. In fact, I can't remember much about my ER visit except that I was very ill. I just wanted to let you know that I appreciate everything they did for me. I really don't think I would have survived except for the extraordinary care I received that day. The professionalism of your nurses, CNAs, lab techs, respiratory techs, housekeepers was above reproach. The doctors themselves came in. They made sure that I had everything I needed, and in some cases things that I didn't realize I needed. But they were just good to me. There is no way I received such tender, loving care and other patients didn't. My heart is full of love and gratitude for each member of your staff. I am not sure how many days I stayed in that room, but I never lacked anything. I was treated as though I was the most important and only patient there. Their dedication to their profession and their empathy for their patients was in every action and word. At the end of this letter is a list of all who participated in my care and healing. I just want to let you know that each of the people on the attached list was a point of light in my healing that joined together to become a beacon on a lighthouse of love, care, and hope. I thank God for North Oaks and for the integrity of your staff. God bless you and strengthen you in your task. Sincerely, Faye Lavelle Cannon.
Thank you, Ms. Faye, for sharing your story with us. We appreciate it. And as you can see, it takes a village to take care of one patient. It takes all of us. It doesn't matter what department you work at here at North Oaks. We're all part of one team, committed to doing one thing, which is improve lives every time, every touch. What we'd like to do now is, if you have a question that you would like for any of us on the executive team or our board to answer, if you will raise your card and a member of our team will pick it up and we'll go through your questions now. While we're picking up the questions, just to let you all know, this is National Hospital Week. It's the reason why we chose this week to do our first community forum, and it's also National Nurses Week. And so on behalf of the administration and board, we would like to thank our staff and our nurses for the care that they provide to this community. Okay, the first question that we have, can we build a walk-in clinic at the ER for patients that aren't emergent as the other patients? And we actually have that for 12 hours of the day. When you come into the emergency department and you are triaged, which means we check to see if it is something that needs to go immediately to the back or can wait. If it is between 12 noon and midnight, we have an urgent care that's separated off of our emergency department. And so we will send the patients to that area to be treated by a nurse practitioner and or a doctor instead of being in the trauma ER. But we do have that 12 hours a day. We also do offer 3 other walk-in clinics, one in Hammond, one in Ponchatoula, and one in Walker, to try to help patients as well. The next question is, please discuss the difference it makes in billing depending upon a patient is classified as an in-house patient or admitted for observation. Rob, you want to talk about that one?
This unfortunately is extremely confusing to especially the layperson, because the only thing that they see is they got a bed in the hospital. And so there's a number of different statuses that, by the way, this is not the hospital's idea, this is the insurers, and this started with CMS. And so the idea behind observation was, for the patient, a good example, the original reason it was done, and my training goes back, I've been in Hammond, next year will make my 20th year here since I trained. Appendicitis, we didn't put you in a CT back then. The way you did it is you put somebody in the hospital for 8 or 12 hours and you did serial exams on those patients to check their belly by pressing on their belly and seeing if they got worse. That was the original reason we had an observation status. We didn't know if you were sick enough to be in the hospital and need that kind of care. What it's evolved to is now they've got tons and tons of rules that tell us when a patient is an admitted inpatient status, which is different than an admitted observation status. And the difference, if you're a Medicare recipient, is the difference between Part A or Part B. And the reason that's important is because there's a lot of different charges that become your responsibility, i.e. somebody you're paying and not your insurance company paying. So what we've seen in trending over the past few years is all of the insurers, Medicare, Medicaid, private insurers, have all really pushed this particular status because it is a decreased payment. And so there are a lot of things as a physician, and the other physicians will shake their head on here, that we know somebody is incredibly sick, yet they will tell you that they're an observation patient. And a lot of those do convert to inpatient, so that's okay, but it does put a different burden on you, and it's extremely confusing to you guys as patients. And gosh, even our own employees that get put in this status don't even understand that billing aspect of it and their potential financial liability. But we are bound by rules that we have to follow on what those that financial liability is. So although it's confusing, it is the rules. Does that answer whoever's question that was?
Okay. The next question was, how can we help North Oaks? So I'll let anybody answer. How can they help North Oaks? Come to North Oaks. Okay, so how you can help North Oaks is, one, please come utilize us. Don't leave town. Come to North Oaks. We hope we've demonstrated everything we're doing to give you outstanding care right here close to home, to show you the breadth of services. We do everything at this facility except transplants and severe burns. Other than that, we can take care of you right here. And we're bringing in the latest techniques as demonstrated by Dr. Abraham. The other way that you can help us is if you hear somebody say something that you haven't experienced firsthand, and if it's negative, I would ask you to say, please call Michelle at North Oaks. Tell her. Because unless it gets to us, we can't fix it. We can't investigate it. We can't verify if it's actually true or not. There may be a reason for it, but we will be the first to tell you that if it wasn't an exceptional experience, we will own up to it. We will disclose, we will tell you. So what we would ask is, if we do outstanding care, tell everybody. If we do something you don't like, tell myself or tell any of this group up front. And that was the reason why we put them up front, was because we wanted you to see who to call if you have any suggestions for us to improve your community hospital. Because this is our community hospital, and we're here for the people. We don't get bonuses, because every cent we make must be reinvested into this community through new services, new equipment, and jobs. We're the number 2 employer. We employ over 2,600 people. Our payroll, if you turn it over just 3 times, you use a very conservative economic multiplier, it has $750 million impact on this community. Business look where they have strong health care to relocate. So we need to be here so that our parish can flourish. There was one, I wouldn't say it's a question, it's from a gentleman who asked to make a comment, Mr. Gary Sanderford.
I just want, I don't know if it was appropriate, I didn't have a question, but when I heard about this, I thought it was important for me to come and to support y'all, because out in the business community, I hear all these myths. We all have. You have to be naive if you don't. And I think Ms. Cannon very well put all the things I wanted to say, because Joanna and I have been in here. I have been in the I've personally been in the emergency room, and I think back of people like Janet Waddell. I think back like Jackie Carr. I even think of Rob poking his head in my room that day, and I'm thinking, what's a chief medical officer doing in my room? You know, and I'm sitting lying there contemplating my morbidity and mortality. We've had 3 grandbabies born here, and I think that we have a facility like y'all, and that we're confident. I have a 96-year-old godmother that has been here too much in the last 6 years, and bringing her in here, the compassion and the patience and all of that, who has dementia, I just am very, very pleased and appreciative that we've got something. And I will tell you this, some of y'all know this, but I'm a 37-year volunteer firefighter in EMR, emergency medical responder. As recently as last night, there was a number of us were being recertified by Acadian Ambulance for night landing training. So in the event that we got to call a dust off to take patients out. And that came up about y'all being the trauma center last night, and how much that is, just what a tremendous asset that is in the community. And frankly, the insinuation was probably be less dust offs called in or chopper evacuation, you know, particularly on the south end, because it's not going to be an advantage as opposed to road transportation and all. But I just want to thank everybody there, and I thank Ms. Cannon, because she did it a lot better than what I'm doing now, as far as what I wanted to say.
Thank you. Yes, ma'am.
This is a perfect segue for me, because I didn't fill a card out because I don't have a question. But a perfect lead-in for me. My name is Avril Font. I'm a retired educator, and I work quite closely with the schools in Hammond. And I don't have to tell you that perception is everything. And the reason I'm here is I was one of the 1,600 trauma patients that you had. I had an accident to my leg 2 years ago. And fortunately for me, when I came to the emergency room, the trauma surgeon was in the operating room, and therefore I was under the care of the trauma surgeons from December through May. It wasn't just the surgeons that impressed me, it was everybody. It was the office staff, it was the nurses, it was the kid. I felt they cherished me. And to be perfectly honest, when they dismissed me, I was disappointed. I knew that I wasn't going to see them again. And I just want everybody to know that the care that I got from everybody at North Oaks was outstanding. And I think that the reputation the hospital has, people need to hear this. And that's why I came this evening.
Thank you, we appreciate it. I know we had 2 parish councilmen join us. I didn't know if you all wanted to say something.
I'm just here to listen, but how many, I say this all the time, anyone in the state would love to have this facility in a parish. I experienced it, I've had my now son-in-law had a serious accident, so he was, I think, one of the first ones, trauma patients that was here in the hospital. You know, my mother is 94, so we've had a lot of experiences here with her, and it's really a great place, and it's a very vital asset to the community. And everybody needs to understand that it's really a great place. And it just, as you said, employment-wise, from care to everything else under the sun, it's really a wonderful place.
Okay, thank you. Mr. Buddy?
I'm Buddy Rachel. I'm speaking more as a person who uses the hospital than a parish councilman. I have a son that's 40 years old. When he was 33, he broke his neck, and you went to trauma center then. So they sent him straight to Baton Rouge. From there, we went to Atlanta, Georgia, to Shepherd Center. But when we got back home, we had to get some doctors. And we have, I think, 7 doctors here at North Oaks, every one of them. In 7 years, we come up here every now and then for situations, but we don't have to leave Hammond for anything. All the doctors are right here, and they take care of them very well.
Okay, thank you.
As everyone is saying about their experience here. When I first moved here 4 years ago, I had an extinct bowel, which they say very few people survive from that. I could have not gotten any better here. The ICU unit was very well, and then I went to the North Oaks Rehab, which I'm telling you what, those people don't get out that bed over there. The guy named Gola has better chance in the state than we do. But I had very good care. And just a few months after that, I had strangulation of the intestines, and I came back here. So, I mean, I could say only the best about North Oaks and everybody that works here. And then I said, well, you know, it's kind of expensive, so what am I going to do to pay these people back? I called up North Oaks, and they asked me, well, how much can you afford a month? And I told them, and they said, well, what time of the month would you like your bill? And I told them that. Now, I've been paying on that thing for 4 years now, but let me tell you, who else is going to do that? So good. So I have nothing but very good things to say about North Oaks.
Thank you. Dr. Pat?
All the questions been answered yet?
Yes, sir.
Okay. I want to add to the accolades that have been expressed here today. I'm 83 years old. I'm probably one of the oldest patients that North Oaks has had over the years. For 53 years, I've enjoyed the services that North Oaks, beginning with 7th Ward, has been able to give this community. It's had wonderful leadership over those years, particularly Jimmy Caffey for 30 years. He basically dedicated his life to this community. I've told him many times, I thought he was maligned many times for no reason, and he should have been congratulated. They were smart enough, this Board of Commissioners, to recognize that Jimmy, over the years, had groomed an individual who would continue what he had given to this community. And his recommendation was Michelle Sutton. And Michelle Sutton is going to lead this North Oaks Health Center even into greater things. in the years to come. And I personally want to thank this Board of Commissioners. They're good people, they serve this community, they do not get paid, and for all those that have served in that position, we owe them a debt of gratitude for the support that North Oaks has provided this community for the last 50 years.
Thank you. Okay.
May I make a statement?
Yes, sir.
Retired after 50 years of ministry to the Hammond area, and then over the last 10 years, I've served a number of churches on an interim basis. And I heard a lot of comments. And I went to Blake and shared with him the kind of comments I heard, and that we didn't have the information to answer those questions. I appreciate you taking the time today to give us answers to the kind of questions we hear in the community, so we can help people have a better, deeper appreciation for what they do have in this community. If I didn't know it before, I just spent the month of February in SICU and the month of March in rehab, and I'm still under the care from a major operation that I would have had to have gone to probably to Dallas to have had done, but we were able to do the surgery here. And I was glad to be able to stay at home and not have to be transported back and forth or finding someplace else to stay. But mainly just wanted to say thank you for taking the time, all of you, for giving us information that helps us have a better appreciation and can answer questions that we hear in the community.
Thank you. In addition, members of our communications department are passing out a copy of the slides that we went over tonight. So we're giving you what the myths were and what the facts are, so that if you hear something in the community, you're now armed with the information to correct them and give them the right answers. So with that, I guess I'll ask if there's anybody else, any of our board members who want to say anything before we close.
Yeah, you shouldn't do that, Michelle. I do. Michelle mentioned that she was going to ask, but she didn't know anyone would accept the offer to come and speak. My name's Ron Macalusa. I'm from Hammond. And I've been on the board now about 2.5 years, almost 3 years. And we're board members are appointed by the parish council. There are 5 of us. Dr. Satoon is correct. Thank you for saying we're not paid. We're not reimbursed per diem. We don't get anything, nor should we. So what is our role? We serve a 6-year term. And the 5 of us come from the south end of the parish, the 7th Ward area for which the hospital originated. So who are we? We are you. We are your eyes and we are your ears. And all of us, and Dr. Barsley came in a little late, but he's here from Ponchatoula. Look, we're at the website. My number is there. I, like Michelle, want to hear, thank you for the great stories and experiences that you have here. That's how it should be. But 2,600 employees, as many patients as come through, under the circumstances that they come through, their illnesses, there are issues. We realize that. Our leadership team realizes that. We want to be better, everybody, top to bottom. So
let your neighbors know. Let your relatives know. If there is something that they can tell us to make us better, I consider that constructive criticism. I don't consider that just bad news. As Michelle said, and I want to compliment her leadership and the management team's leadership, we need to know if there's an issue. We'll do our best to solve it. Our role as members of the Board of Commissioners, besides being your eyes and ears, our task is to look to the future as to how this facility can best serve our community. We're just like the police department, the fire department, because when you need us, you need us. We need to be here. Okay? And I don't need to share with you the challenges that are in the healthcare world these days. So, predicting how we're going to be in the future, there's a lot of smarter people, I think, in D.C. and Baton Rouge can't figure it out right now, but we're trying to do our best. But we need the community support. We do. We need you to be ambassadors for this facility and to let people know. I've heard complaints about the hospital, not from the people that have been treated here. The complaints that I hear is, oh, well, somebody said this and something happened, whatever. And you know how that is. I mean, everybody knows the fable about the blind man with the elephant, and, you know, and you get 10 different versions of what the elephant is. But I'm going to tell you, if they come through this facility, 99.99% of the time, they leave going, wow, I'm impressed. I don't take any credit for this, by the way. Dr. James Nelson was on the board. He left a few minutes ago. We've had some great Judge Brent Dufresh, this particular building's named after. These people have done a terrific job. We're the beneficiary of that good work. The good work of Jimmy Cathy, Michelle, Parish Council's involvement. But we need your help. I have probably now run over I didn't have any allotted time, but I just couldn't leave without thanking you for being here. And if y'all have any questions now, ask me.
I don't have a question, but I feel like I would be remiss if I did not, and I wasn't asked to say this, but I was a patient here. 4 years ago, I had a heart attack. I did not know that afternoon when I was at home that I was in the middle or beginning of a heart attack. I had mild symptoms. So that's one message I want to tell you. You don't always get those really bad symptoms. But once the symptoms got a little worse, I said, you know, I think I might be having a heart attack. I better get to the hospital. A friend was over and drove me to the hospital. And when I got there, I walked in by myself. I went to the front desk at the emergency room and I said, I'm having some minor chest pains. Now, I didn't say I'm having a heart attack or anything like that. I just said I'm having minor chest pains. And immediately, they took me in, and when I saw people rushing in within just a couple of, maybe a minute or so, I kind of thought, am I having a heart attack? And they said, yes, you are. I was in the middle of a heart attack. And to make matters worse, once they got me in the back, which was right away, my heart quit beating. They had to shock me back, the paddles as they're called. And every second, every minute counted. If they had not acted so quickly, I would not be here today. And so I am so thankful to North Oaks, and I just, you know,
Thank you,
and
Betty.
God, of course, and I'm just real
Thank you.
thankful that I went there when I did.
Thank you, Betty. And we would miss you if you weren't here, so thank you for being here. Thank y'all very much. Thank you, Michelle.
All right, enjoy your evening. Thank you for coming.
Thank you.